I am Dr. Beverly Reed.
And I'm Dr. Amber Klimczak.
And we are Two Peaks in a Pod. Well, hi, everybody. Welcome back. We got a few weeks off, didn't we?
It was nice.
Yes. Okay. We both went on spring break. Did you have a good spring break?
I had so much fun.
Yeah.
My kids had a blast.
Good.
My oldest just really enjoys vacationing. She lives her best life on vacation.
Yes. That's great. That's great. We had a good time too, but it's good to be back and we got to get back to it. And I read a funny story. You know, I'm all into celebrity news. I read a funny story. I went to share it with you. So this is about Real Housewives. And so I know you don't watch Real Housewives, but there's all different franchises based on the city. So this is Real Housewives of Beverly Hills.
Okay.
There's somebody on there named Erika Jayne, and she's a very fabulous character. Okay. So she was married to this very wealthy man, but then he got in trouble because he was allegedly stealing money from his poor clients. Oh, and that's how they were so wealthy. He was a lawyer. Yep. And he was trying to, help his clients get settlements, but then I guess he was allegedly keeping it himself. Okay. No. So then they got divorced. She left him through all of this, but then he's claiming that he had dementia and that's why he took their money and everything and all the rest of it. So she's like moving on with her new life, single Erika Jayne. And
how much older is he than she is?
Oh, way older. Probably.
I'm like, the dementia thing is not lining up for me.
Yes. Probably twice her age. Yes.
Okay.
And so it's interesting. So apparently she was talking to the other ladies on the show and she tells the ladies she lost a lot of weight due to taking hormones for menopause. And then one of the other ladies responded, of course, at a separate time in her own confessional interview. She said, "Oh, are hormones spelled Ozempic, Ozempic?" And I laughed and I thought, oh my gosh, that's actually, I feel like has some truth to it. And so I thought maybe today we could kind of talk about hormone imbalances. What are they? How can you test for them? How can we treat them? And really a lot of it is because this comes up on Real Housewives all the time. So, I'm sure you've heard these women are very dramatic. They've got many things going on. And it's often a feature of the episode that, I need to get my hormones checked. And maybe that's why I'm the way I am.
You're acting a little off.
Yes. But I will say, I guess not so surprised ending is they take hormones and then they're still quite dramatically. So I think we should all learn from that. But first, I just kind of wanted to touch on this, and I just wanted to ask you, what is a hormone imbalance?
I know. I actually think this is this super relevant question. Yeah. I agree. I had so many of my patients come to me and are really worried about a hormone imbalance. But hormone imbalance is not really a medical term. I know that doesn't sound, it doesn't sit well, I think, with our listeners and maybe patients out there. But when we went to medical school or residency for OBGYN, there's not like some diagnosis that you look up that says hormone imbalance, and that's what's going on, right? This is sort of an umbrella term, really even more so used like in the community and non-medical community as, just an overview of something being off, right? With your menstrual cycle. So there's no diagnosis that we've ever written or coded to insurance that says hormone imbalance. For a patient, which is kind of hard to swallow, I think.
I know. And it's so true. I will say for the most part, if I see somebody on social media touting, do you have a hormone balance? I can picture hormone imbalance and everything. 95% of the time, that person is not actually a board certified hormone doctor, which blows my mind. And sometimes there's specialties you're like, why are you a dentist treating hormone imbalance? And so I think that brings up an important point when you're taking advice from anybody. You always want to look and see what are their credentials? Who is this person? What, are they not even just a doctor, but are they a physician? What did they train in? I also think it's a bit bizarre that you have sometimes doctors that didn't even train in anything that has to do with hormones, and now suddenly they're claiming to be hormone specialists. And so, maybe some doctors just made a later in life change, but I think it's important for you to at least know and understand their background if you're going to be taking advice from them, right?
Absolutely. And for a safety thing.
Yeah.
Before you take any medications or anything.
Yeah, but I kind of feel like maybe it's a way of almost taking advantage of common problems that women may have. Certainly as we get older, because I'm entering that age, we can be more tired. We can have trouble losing weight. We can have mood swings, all these things, right? And it's such an easy answer for people to constantly tell them, you need to have your hormones checked. You have a hormone problem, this and this. And as women, wouldn't we love to believe such an easy answer? Oh, it's my hormones. I'll just take my hormones and I won't be like this, right? I wish that was the case, don't you?
Yeah.
Don't you wish it was that easy?
Definitely.
I'd be giving myself all types of hormones. And so I think the truth is, and something we really need to know and face, is that hormones are incredibly complex. And here's what's important to hear too, because you see all these experts online. We are double board certified hormone experts. And I'm here to tell you, we don't know everything about hormones yet. It hasn't been discovered in our field. We are still trying to figure it out.
Very true.
And so it's important to know that, so that anybody who's appearing to seem like they know all the answers, that's probably not the case, right?
Very, very true. Yeah. And I think the term hormone imbalance implies that there's this perfect recipe for every person, and that if you're fitting this perfect recipe, that you're going to feel normal and your cycles are going to be normal, and maybe that's going to get you pregnant if you're having trouble with fertility. But the truth of the matter is, there's not just some tests that we can run and see that you're imbalanced and then rebalance them and that corrects everything. I think that's what the perception of a hormone imbalance is. Right?
And I do think it makes it seem like these hormones stay the same levels all the time, right?
Exactly.
And so one thing I would encourage you guys to do at home is just Google or ChatGPT, your favorite lately. Google, what do my hormones do in a normal cycle? And what I really want you to see is the graph showing your estrogen, your progesterone, your LH, your FSH, and see how dramatically they are changing all throughout the month in a normal woman.
Right.
So it is normal. And so I've seen cases where a patient comes in and she says, well, I saw this expert from social media and they said, I have low progesterone. And I look and I say, well, they checked your progesterone on your period. Everybody has low progesterone when you're on your period. That's normal. That's why you had a period, right? They were checking it at the wrong time of the cycle. And so it's just an example to show you hormones are dynamic. They change and they're supposed to change. That's what they're supposed to do. And so I feel more so concerned if your hormones aren't changing like they should, right?
Yes. Hormones are dynamic. And I always explain to my patients, they're released in a pulse, right? So there you get a little spurt, it goes away, you get a spurt, it goes away. It's not just a constant release of hormones. So anytime you're getting your hormone levels checked at one precise time, it's kind of difficult to interpret, right? With just one data point, you really need to see something trending over time to understand, is something truly deficient or not?
Yes, absolutely. And I say all of this, and I'm not trying to say that there aren't women with hormonal issues. There certainly are. But I guess what I'm saying is, to me, it's almost portrayed that 80% of women have these hormonal issues. And I would estimate it's more like 15% or something like that, right?
Yeah.
And so it's not to be dismissive at all. There are certain women who definitely need an intensive workup to try to know and understand what is going on with their hormones. But I don't want people to think that there's necessarily anything wrong with them just because all your friends and family are saying, oh, it's probably your hormones, you need to get your hormones checked. But I do love how this example from Erika Jayne that I just told showed, I do believe a lot of times it's the hormone, but not that hormone, right? It's the hunger hormone that can really, over a long time, essentially cause us to have insulin resistance. And insulin resistance has been shown to cause fatigue and increase in abdomen fat, and all sorts of issues like this. And so I think maybe that's where we've really missed the mark over the years, is we're telling women, oh, you need estrogen, you need progesterone, or whatever the case. No, Dorit is probably right. A lot of people probably need some Ozempic, which we're happy to be able to offer that these days to people as well.
Yeah, so. Definitely.
And I always use an example too think of a 10-year-old child, right? A 10-year-old child is full of energy. They're usually pretty thin. They're usually pretty cheery. They're not grumpy. They're not having mood swings or anything. And what are their hormone levels? Hormone levels are 0, right? They haven't gone through puberty yet. Yeah. And so that alone should tell us it's not all about hormones. In fact, once the hormones kick in, that's when sometimes people start getting a little grumpy, right? Yeah. So I don't know that filling people with hormones all the time is necessarily the right answer to treat some of those symptoms either. So, okay. That being said, how can we tell if somebody has abnormal hormones? Like, what kind of evaluation should we do on those patients? Or is there even anything they can do on their own at home to check their hormones?
Yeah. And I mean, one of the first things that I always sit down and do with my patients is I just listen to their history, right? So we take a really thorough history. I want to hear about what your symptoms are. What are your menstrual cycles doing? Are you having regular menstrual cycles? Have your menstrual cycles changed over time? Are they different than how they used to be in your younger years? And so history is really important. And most of our women are pretty good at tracking their health, especially now. I think women have a lot more awareness about their menstrual cycles and keep track of them with apps and things like that. So one of the tools that I think is really helpful and pretty straightforward is just tracking your menstrual cycle on an app so that you have some data for me to see over time. Okay. And is it persistently changing or persistently off over several months? That really helps me to understand, because it can be more common to maybe have a one-off cycle that was a little bit off for you, right? But when you have something trending over time, it's really helpful for me to interpret.
Yes, absolutely. And I think that's important for people to hear, because I do feel like a lot of patients in this situation are targeted with marketing ads on Instagram and all the rest of it. You need my fancy monitoring device and all the rest of it. And I do think, hey, that's kind of cool that they have all these devices nowadays. But when somebody asks me, do you recommend this? I usually say, no, you don't need to do that, because if you have been tracking your cycles, you can have me look at it and I can make a lot of conclusions based on that history alone. And let me tell you, if you are listening out there and you are not having periods at all, you need help. You need evaluation, because you are likely not ovulating. And that is an easy issue usually for us to be able to help you with. Other patterns that I will look for with the period is if the periods are super spread out, or if they're super close together too. And, or like you said, if they're irregular, sometimes they're close together, sometimes they're, spread out. These are all really important clues to us that there is some kind of dysfunction going on with that ovarian hormone pattern. And the good thing is, I would say usually these are very treatable conditions too, when compared to all the different type of fertility issues that can go on as well.
Yeah, definitely. And when we look at the history, I think the other kind of misconception is that sometimes patients think, oh, well, we just need to add back this hormone. I need more estrogen, or I need more progesterone, and this is going to fix all of these problems. But I think the difference about what coming to see a reproductive endocrinologist or seeing your OBGYN can help you with is that we really target the source of the problem. Right? I explain it to my patients as, you have a wound that's bleeding, right? Like something's going really wrong. And we can't just slap a Band-Aid on it, right? We got to go in there, look at it, sew it up, fix it properly so that we can have correction moving forward. So we can't always jump to the endpoint of just throwing the hormones back on. We have to really investigate, what's the source of the problem? Why are you having changes in your menstrual cycle? Why are you missing your periods? Why are all of a sudden your cycles getting closer together?
Absolutely. And so when patients ask me about these fertility monitors, I say, well, I don't recommend them, but of course, if anybody wants to use a fertility monitor, we're never against that. But I will caution you, because people bring us their results quite a bit. I've already seen some of them be incorrect or wrong.
Definitely.
Because, some of them will be panicked and they'll come in and they say, look, I ovulated, but my monitor is saying I had no estrogen. And I said, that's actually impossible to grow a dominant follicle and ovulate and have your estrogen be zero. So I'm like, surely that's inaccurate, but it is hard, right? Because sometimes the patient may say, but I don't understand. My monitor's saying this. So we'll prove it to them. We'll check the serum level, the actual blood test, and show, see, you do have estrogen. Okay. And then they feel kind of reassured by that. But it does kind of bother me to know that even in the short period of time that these monitors have been out, I have been able to see some inaccuracies that really stress our patients out.
Yeah, I mean, these are direct to consumer tests, right? These are not tests being administered by a doctor or a hospital, so they don't have the same validation requirements that our blood level test have to have. And so again, like that can be risky for you, right? If you're relying too heavily on them. The other thing that I really see that happens to my patients is it adds more stress to your daily life, right? If you're already trying to get pregnant, maybe things are not going as you expect. And then you start having to do daily hormone monitoring and tracking, and you're trying to take control over it. I think that's exhausting. Like, I think doing the LH ovulation kits are exhausting enough, you know? This is hard work, you know? And so sometimes I say, look, you don't have to do this anymore. Like, let me take this off of your plate. This is my job. You know, this is what you're paying me to do.
Well, and I'm glad you brought up LH testing too. So a lot of ovulation kits, well, really probably all ovulation kits, are detecting your LH hormone that comes from your pituitary gland. And usually we would get a surge of this as we're about to ovulate. But there's a condition that many women have called PCOS, polycystic ovary syndrome, in which their LH levels are chronically elevated. And for those women, doing that at-home testing is so confusing because they will have times where they're testing positive for days on end. If it's a true LH surge, you usually should be positive for a day or two, and then that LH goes back to normal. And so that's another example where the at-home testing or monitoring is totally throwing off your chances of being able to get pregnant.
Yeah. And then you're still sitting there trying to monitor it and you're like stressed out about it.
And keep buying more tests, which I'm sure the companies love.
Exactly.
And so I've really found sometimes in patients who have been doing a lot of home monitoring, when they do come and see us and we're able to do ultrasounds and actually show them, and they get to see, you can actually see on the ultrasound your follicles growing. We can even bring you back later if you want to see that they popped and ovulated. And I found that regardless of whether you get pregnant or not, it's such kind of a relaxing phenomenon to get to know for sure what is actually going on with your body.
Yeah, I've actually started doing a little bit more monitoring of natural cycles with my patients, especially patients that do have just unusual histories, you know, and maybe aren't ready to start treatment. We'll spend just like a month kind of looking with ultrasounds and blood work and just seeing what they do naturally. And I think it's interesting because it's not something we do on a regular basis. We're not monitoring a ton of just regular natural cycles. So it's interesting for me to gain my own data too about, I mean, it's highly variable, I think is the other thing that you just really have to be reassured about. Maybe your hormone tracking at home is actually appropriate for you and your body is doing exactly what it needs to do. And there's not something abnormal going on, you know, and then when we bring you in, you're doing everything that you were supposed to be doing. We can see that you're ovulating, but your levels fluctuate and are slightly different than average.
Now this may gross some people out, but here's a way to kind of check your estrogen at home, right? Is as you grow a follicle, it makes estrogen. Estrogen actually helps make fertile discharge. So your discharge right before ovulation will probably become more copious and clear and stretchy. And so if you see that, that's a great hint right there that, hey, your estrogen level is looking really good and you are probably going to be ovulating very soon. And then after you ovulate, if you look at your discharge, it should also change characteristic where it becomes more of like a thick viscous and maybe less discharge overall. And what's interesting too is they've looked at studies. If you are seeing fertile discharge, if you get breast tenderness after your ovulation, and if when you have periods you have cramping, if you have all those symptoms, those are called meliminal symptoms, there is a 95% chance that you are ovulating. So just knowing that information alone without doing an ovulation test is often just reassuring to let you know, hey, it does sound like your body is at least in the right pattern overall.
Definitely.
Mm-hmm.
Yeah.
Okay, so let's say we've got a patient and let's say she's not having periods and she comes in. What are the kinds of evaluation that we can offer her to help her figure out what is going on?
So usually I start with blood work and an ultrasound. We're going to try and investigate for some of the common causes that are leading to not ovulating. So on blood work, we will often check things like your prolactin level. Sometimes that's a hormone that can turn on your brain on its own without really the signal to occur, and that can cause you to stop ovulating. Your thyroid could be off and preventing you from ovulating, not having regular cycles. You could be pregnant.
Yeah,
that's
true.
Cycles,
that's true. I've seen that happen before. As fertility patients, sometimes they feel like that's not even a possibility. So yes, I've
had a few, or and that's always a good thing to have. So we always check your pregnancy hormone level, and we check some labs like androgen or testosterone levels to look for maybe symptoms of PCOS, which we talked a little bit about, polycystic ovarian syndrome. So there's a lot of these common reasons why someone wouldn't cycle and is not ovulating on a regular basis. On ultrasound, we look at the ovaries and uterus. The ovaries can sometimes give us a hint to, do they look kind of like this polycystic appearance or not? Occasionally women could run out of eggs early. We call that premature ovarian insufficiency, and their hormone levels and their ultrasound can kind of be indicative of that if things are very, very low. I feel like that's less common, that they totally stop having cycles, but sometimes I see that too.
Yeah, absolutely. And one of the things that's really helpful for us to sometimes differentiate between different conditions is checking our pituitary hormones called FSH and LH. So in women who aren't having periods, a lot of times we say, okay, well, it seems like the ovaries aren't functioning well, but is it that they are kind of in and of themselves undergoing insufficiency, or is it that they're just not getting enough of the signal from the brain in order to produce the eggs like they need to? And so in particular, if we check an FSH level and if it's really high, then that does give us some concern for maybe premature ovarian insufficiency or premature menopause. Whereas if those hormones are low or sometimes even normal, sometimes we even say that's inappropriately normal if the patient's not having periods. And there's all sorts of causes that can cause your brain not to communicate properly with your ovaries, including sometimes not having enough calories in your diet, or maybe exercising too much, or maybe you had some sort of brain trauma from a prior car accident or things like that. So I do think that checking those hormones in that case is so important. And that's why, kind of circling back to what we were talking about in the beginning, it is important that we don't want to be dismissive to anybody who says they want to have their hormones checked, because if you're not having periods, we agree you need to have your hormones checked. But again, we just want to make sure that we're kind of distinguishing that from just telling any and all women who are having symptoms that, oh, it's because of your hormones.
Yeah, absolutely. I would say the other pattern that I think is important to address for sort of a hormone imbalance that we'll see quite frequently is that sometimes women report that their cycles are getting short.
Yes.
They're getting closer together.
Yeah.
And so this is one of those times also that you might be monitoring your hormones at home and you're like, something's not right. My levels aren't getting up to where they used to be. Sometimes this is when people might perceive that they have low progesterone, or their OBGYN might have checked like a progesterone level and you have a low level. And this can all be a sign of ovarian aging, right? As we get older and the quality and quantity of our eggs go down, one of the first signs is actually that our cycles get close together. And so they shorten up. And especially when the quality of the egg and the follicle that you're developing are lower as you get older, it can really throw off some of these levels and even the absolute levels of hormones that you're checking. Sometimes I have women who have really low egg quality or low egg reserve. And even when their follicle should have ovulated properly and switched to releasing plenty of progesterone, it doesn't do that properly. And they really truly can have, I would say, a hormone imbalance, hormone deficiency. We don't use that term, but like I would say that would qualify, right?
Yeah.
Their hormones are not acting as they should at the proper time in the cycle. And that's something that it's tricky, again, because sometimes it doesn't help just to give extra progesterone or extra estrogen to do it. Sometimes you have to start back at the beginning and figure out what else can we do to help improve the whole nature of the menstrual cycle.
Yeah, and we do have really cool ways of hacking that too. Absolutely. But I do want to, it kind of just made me think of this too. We're kind of talking about fertility patients, but the other group of women that have a lot of hormone suggestions are women in perimenopause or menopause. And sometimes they will say they're frustrated because, and I will say this is how I was trained as a regular OBGYN before I was a fertility and hormone doctor. This is how I was trained many years ago, is they said you don't necessarily need to check labs. And that seems to frustrate patients a lot because they feel like, oh, well, my doctor's not listening to me. But no, this is the reason that they didn't check labs, at least back then. They would say, look, if a woman comes to you and she is having hot flashes and irritability, and she thinks that she is in perimenopause or menopause, believe her. She is. If she's in her mid-40s or 50s, she is in perimenopause. You don't need to check blood work. You believe her and you give her hormones, And I think there's a lot to be said about that because I feel like it was almost framed in a different way sometimes where people would be like, my doctor's not listening to me. They won't check my hormones. It's not that I think they're resistant to checking hormones, but I think what they're saying is, look, we don't need to believe a blood test. We believe you and we're willing to treat you for your symptoms because if you're having symptoms, that is enough for us to know we want to help you.
Right. Absolutely. And I think there's something to be said as to something can be really, really common, right, for a woman, but whether or not we're going to interpret that like as normal and acceptable to live your life, because it's really your perception of what's bothersome to you. Women experience perimenopause or hormone fluctuations, right, as we get older in all different ways. There are some women who will go through perimenopause and menopause and not have any perception that it's bothersome to them. There are other women that are miserable. Right. And so I think it's really hard when you go to your doctor with any symptom and they say, totally normal for your age. We get this like in all phases in our life. When you're pregnant, you're miserable when you're pregnant, right? Totally normal. We write off a lot of things, right? But I think that's frustrating being the patient where you're like, this doesn't feel normal for me. Even though this might be extremely common, I'm not happy with the way that I'm experiencing this time in my life. Are there any treatments available to me to help me? And yes, hormone replacement therapy is a treatment that's available to you that can alleviate a lot of those symptoms for women. It's not a perfect magic bullet, right? It's a lot about lifestyle during that time in our lives. Our diet and our exercise and our activity level can affect these things, but hormone replacement therapy can help a lot of women. And so to be told it's normal, keep on living your life, I think that's extremely irritating.
Absolutely. And so I do think those are the patients that deserve to be mad and to be dismissed is you came to your doctor with a problem, they didn't do any labs and they didn't give you any treatment. Now that's not okay, right? They need to be doing one or the other or both, but I think, really I just wanted to reassure patients that for the most part, if you're going to a reputable doctor, they do believe you. We know this is a common issue. And there are treatments that can help you feel better, both hormonal and non-hormonal treatments that can help things like hot flashes and things like that too. So, okay. So let's say we've done our evaluation. We know what's going on now. What are the treatments?
I always tell my patients, your diagnostic testing really dictates your treatment options, right? So again, I really like the way that I like to treat my patients is very precision method based. I look and see what's the source of their problem and how do we correct it. So it really depends on what did we find on your testing, right? Is it that your brain is shut down? Is it that you have PCOS? Is it that you have low ovarian reserve? And then what are your goals, right? Are you just trying to feel better? You just feel like your hormones are off, or are you trying to get pregnant? It depends on which kind of timeline and goal you're on. Yeah, absolutely.
Can I share with you some of my pet peeves that I've seen over the years? Okay, so one of them is progesterone. And here's the thing, I love progesterone, okay? I give progesterone out like candy, okay? But here's the thing, guys, please listen to this. You should not give yourself progesterone without being under the supervision of a doctor or a physician. And I would maybe even say a board certified fertility expert or somebody who knows what they're talking about, because I've seen multiple cases over the years where a patient had infertility, and it was because they were giving themselves birth control without knowing it. Because here's the thing, when I give progesterone to patients, I'm giving it to them usually about 3 or 4 days after they've ovulated. If you take progesterone before you ovulate, progesterone can lower your LH level and keep you from ovulating and give you a cyst sometimes too on your ovaries. And so I truly had a patient who came to me one time. She said, my chiropractor said my progesterone is low. I've been taking this progesterone cream they gave me every day for months.
The creams are very common.
Yeah,
people using the daily
because they can get them themselves, right? Take the cream. And I said, okay, let's stop the cream. She stopped it. She got pregnant immediately. She thought I was a miracle worker. And I'm like, nope, I just stopped your birth control. And so it is really important. Don't take progesterone every single day, not before ovulation. Even after ovulation, I think you should check with your doctor because maybe not all people need it. And so that's definitely one of my pet peeves for hormones.
Yeah. How do you feel about, this is a tricky question, I think, for Dr. Reed, women taking testosterone?
Okay. This is tricky too. And oh my goodness, don't get me started. I actually published a paper on this, so I can I can get really revved up on this. So it depends. But what I think we should do is actually learn from nature on this. Okay. So one of the most common things in the Dallas-Fort Worth area are these little low T clinics that pop up everywhere, low testosterone clinics. And look, you have to know the business model of these clinics is to tell everybody, men and women, that all the problems in your life are because you have low testosterone. So I highly disagree with this. I think those clinics are very scammy. They're there to make money off of you, and they may actually create health problems for you. And so I'm not a fan. But the hard part is because everybody's so worked up about hormones these days, not even just low T clinics, everywhere you go, there's people trying to give you hormones, including testosterone. My biggest pet peeve is not only testosterone, but testosterone pellets, where your provider wants to surgically implant a testosterone pellet in you, and they often give you either unpredictable or supraphysiologic levels of testosterone in women. And I'm like, this is crazy, Now, here's the thing. Do you feel better? Well, probably. That's why athletes take steroids. Like, you feel great, okay? But should you take steroids long term? No, that's going to be really bad for you. And some of the things you have to think about is if you've been given a testosterone pellet that puts your levels in male testosterone level ranges, guess what's going to happen to you over time? You're going to turn into a man. Your voice is going to get deep. Your shoulders are going to broaden. You're going to have a male appearance. You're going to grow facial hair. You can grow a micro penis. You can get clitoromegaly. And some of these changes are not reversible. Okay. Now, people may say, well, I have a pellet that didn't happen to me. Well, it doesn't happen to you in 1 day or 3 months. It starts happening about 2 years, probably after you've been having testosterone pellets. And what's crazy to me is the solution from these people who put the pellets in say, oh, you're having side effects. Let's put you on spironolactone. This is a testosterone blocker. Okay, I'm sorry. You're going to put somebody on testosterone and then block the effects? Why would you do that? That doesn't even make logical sense. And here's the sad truth of it is I know a lot of these are just good doctors, but they've been brainwashed by companies who want to make a lot of money and sell these pellets. And here's how you know. If your doctor says you need testosterone, which is debatable anyways, okay? If they say you need testosterone, ask them, okay, does it have to be a pellet?
Right.
Could it be testosterone gel or some other form? Because here's the great thing about testosterone gel. It's reversible. If you don't like it, you can stop it. It's going to wash out of your system quickly. It's adjustable. You can, change the dose anytime you need to, right? So why would you force somebody to have a pellet put in that you cannot take out?
Yeah.
Once it's in there, if you have side effects, good luck. Hope it wears off, after
it
at least 3 months.
It is surprising that they can convince patients to do it. I'm like, who signs up for this?
I know. And I've even seen a patient who had a pellet placed and they didn't know she was pregnant. And then she said, oh my gosh, is this going to affect the pregnancy and everything? And look, probably not. But here's the thing. You can't take it out. I guess we'll see.
Yeah.
Right? And so, that gets me worked up about pellets. Now, of course, people who sell pellets will argue about this, right? But again, from double board certified true hormone specialist, I would never let anybody place a pellet in my body. Never.
No.
Mm-hmm, mm-hmm. Now, I will say for fertility purposes, I am really into testosterone lately for certain women. So if I've done IVF on somebody and their response is suboptimal, if they have really low egg counts, sometimes I will prime them with testosterone. But here's the difference. Number one, it's testosterone gel. I can stop it at any time. I can adjust the dose at any time. And number two, it's just short term. Max, they might be on it a month, right? I'm not talking about putting somebody on it for years. And that is going to be the limitation to any study that you see on testosterone replacement in women is I don't think any study in the literature is longer than 12 weeks. And so what we really need to know is what happens to a woman if she's been put on years of testosterone. We know comparing men to women, that women live longer. We tend to be healthier than men, right? So why are we trying to be like them? It should be the opposite, right?
Yeah.
And so, yes, you got me all worked up.
I know. I mean, I think it's a very controversial but interesting topic that we're still researching and looking into, especially, in women going through menopause, because there is a lot of data. Your ovary does release androgens, testosterone throughout your reproductive life. As your ovaries, start to slow down and, go through menopause, certainly those levels of androgens will drop as well. Like, is there some utility in replacement during that time? That's what we're still investigating. But like Dr. Reed said, we don't have enough data. We haven't been doing this for long enough. So it's certainly risky if you're going to kind of dabble in that testosterone replacement.
Yeah. But I do want to say I'm totally supportive of low doses of estrogen in menopausal women. I think that's great. I will likely plan to do that. And if you're on progesterone and you have a uterus, you also need progesterone as well. Sorry, if you're on estrogen, you need progesterone as well. So I am definitely supportive of all those things. If somebody's going to be on testosterone, which again is debatable on whether they need to be physiologic doses, right? As women, our testosterone levels usually like 30 or 35. We do not need testosterone levels of 300. No. Yes. One more point about it too. So back to looking at nature. Let's look at women who have PCOS. Okay. PCOS women have naturally high levels of testosterone, right? So ask a patient with PCOS, or we could ask you, do you feel great all the time? Okay. And maybe it's a little different in your case, but a lot of women have difficulty with PCOS actually losing weight, right? So when somebody's trying to sell you a hormone pellet because they're telling you that's going to help you with weight loss, then ask them, why does a patient with PCOS often have trouble losing weight? Their testosterone level's high, right? And so these are things we can learn from nature itself. Is we can see many women who have high testosterone levels. Testosterone did not fix all their issues. In fact, they often really have a lot of side effects from the testosterone: hair growth, acne, feeling bad, feeling tired, and all those things. And so I would say it's just more complicated, and we don't have all the answers yet, but that is not the answer.
Yeah, I mean, and certainly the association and shared receptors and everything for androgens and insulin.
Yeah.
I think it's scary to try and mimic being a PCOS patient.
Yeah.
I wish that I didn't have high androgen levels, because high androgen levels also means you're struggling with prediabetes and high blood glucose and high insulin levels, which we know is going to shorten lifespan and quality of life over time. So it's not something to mimic.
Yeah. Okay, well, I wonder if this is going to be a controversial one. Do you think we're going to get some bad comments about pellet pushers? They're going to come after us or something. But okay, well, we'll wrap it up for the week. Thank you guys so much for listening. If you have any special requests of things you want us to talk about, please let us know. And if you would be so kind to leave us a positive review, either on our podcast or YouTube websites or on our Peak Fertility Clinic page, we would so appreciate it. All right, thank you. Bye.
Bye.